Hi, I'm Tim, and I'm getting the room set up, prepared for a barium enema. Some of the things that we're going to need right off the bat, you need to have your barium bag and barium. This is a kit for a barium enema. You just want to really follow the instructions regarding how much water to put in. This one in particular is about 500 milliliters. So let me just get that going. While I'm getting this ready, some of the other stuff we're going to need. We have some gloves, some lubricant down there for insertion of the tip, just to make sure that that goes in as comfortably as possible for the patient. We also have a stack of towels in case things begin to get messy. On the actual bag itself, on top of that, we've got the air inducer. I'll show you a little more about that, but before we get there, let me go ahead and shake up my barium. I'm going to shake this vigorously for approximately 20 to 30 seconds. It's probably pretty good. We're using a higher density barium compared to other bariums that we use for, small bowel follow-throughs or upper GIs. On this tube as well, we're using a double lumen tip, which means we're going to be able to introduce air as a contrast, but first and foremost, we have a balloon tip on the actual insertion tip, and you basically blow up the balloon. Maybe one pump gives you approximately 90 milliliters of air. Generally speaking, the radiologist is responsible for putting air into the tube. And on top of that as well, we also have this little blue bulb that's going to introduce air into the colon for a second contrast, since we're doing a double contrast barium enema. So we're pretty much ready for our patient. Before we bring them in, I want to make sure that I bleed out my line. So I'm basically going to unclamp the hemostat down here. There's a little red ball in there that you needed to push up, and basically bled it through to the bottom here. So we'll be ready to go for the patient when the time comes. I'm going to go grab the patient, just kind of get a brief history of maybe why they're having this exam, and also kind of explain the procedure a little bit. So I'm going to go grab my patient. Alfredo?
Yes, sir.
Hi. What is your last name?
Pantoja.
Pantoja. And then what's your date of birth?
June 7th, 1985.
Excuse me. I apologize.
That's all right.
I mispronounce a lot of ethnic names.
That's all right, sir.
So, I've got you scheduled here for a barium enema. Is this correct?
It's correct.
First off, were you able to complete, follow kind of like 2-day diet where we gave you, laxatives, and you're pretty much just drinking liquids?
Yes, sir.
With that? Okay, so,
yes, sir.
Great. So, what are we doing this exam for today?
I don't know. I guess I'm 50
Your
here.
report says something about kind of looking for polyps. Is that correct? Is that something?
Sure.
Got it. All right. We're gonna go ahead and get started. But before we get started, I want to just kind of explain what's going on. It's a barium enema, so we're gonna be moving you around a lot. I'm gonna be inserting a tip into your rectum and blowing up a little balloon so it kind of prevents it from coming out. We're gonna be allowing barium to fill up a part of your colon. We'll also be injecting some air just to get a good visual of kind of what's going on inside of your large intestines. Okay.
Okay.
Just kind of go with me. Radiologist is gonna come in here, and he's gonna do some fluoro on you and take a look, kind of with some live action X-rays. And then once he's done, I'm gonna come in and we're gonna work as quickly as possible because it's really uncomfortable. This isn't easy, but it's better than surgery, let's say. So. We're going to try to make this go as quickly as possible. Just go with me and just do your best, okay?
Well, you have put me at ease.
All right. Well, I want to make sure that this is as comfortable as possible.
Okay.
I mean, truthfully, this will be difficult, but you'll get through it. You look like a strong, strapping young man. Who I'm now going to ask: is there any potential that you could be pregnant? Hypothetically, if you're a female, I'd want to know.
Well, there isn't. I am not pregnant.
Well, then let's shoot you up.
Trying.
Yeah, okay. Well,
let's
go there. All right. Go ahead and hop on the table. So before we get going with the barium enema, we want to just get a scout film. It's a KUB centering at the iliac crest, and 14 by 17 film. So I'm gonna take this shot on Alfredo, probably about 80 at 30. And he's gonna start face down for me, okay?
In the wars or?
No, we're gonna push you in Sims.
Okay.
Yeah. We go ahead and bring over our enema tip. Go ahead and just kind of bend up this right knee. There we go. And then just have this kind of hand, your left hand just kind of hanging up above you. Kind of putting them in this position. It's going to create kind of like a 35 to 45 degree angle. So we're going to get ready to insert the tip now. I want to make sure you put enough KY jelly on here. Enough that it'll go in as easily as possible, but not so much that it's going to easily slip out. So go ahead and take in some deep breaths and just relax as much as you can. I'm going to be placing the tip 1 to 1.5 inches up the rectum. Then I'm going to kind of follow the rectum's contour towards the belly button. Another probably about 2.5 inches, no more than 4 inches. So tip is inserted. Radiologist is going to take it from here for a little bit. So the radiologist is done with their exam, and now I'm going to go ahead and get the overheads. We're going to kind of move as quick as possible. So first one, Sarah, I'm going to try to get you up onto your left side, all the way onto your left. Good. All right, perfect. It's pretty level there. I'm going to go ahead and get my IRs up there. It's a 14 by 17. I'm going to bring this on over. See if this goes any other direction besides. Oh, maybe it has one of these.
I'm having a hard time holding it.
I understand, Sarah. I'm just gonna need you to take deep breaths and do your best, alright? The sooner we get this done, the better for both of us, okay? Alright. Continue with those deep breaths there, boss man. I know it's tough.
These are tears of joy.
As it goes, we're gonna really pour some ignorance it. All right. We're centering at his iliac crest, approximately right there. I'm about center as it is. I want to be also centered to his body. Just gonna make sure I've got the collimators opened up wide enough. All right. I'm gonna go ahead and shoot. I'm shooting at about 100 at 10. Click, click. All right. My colleague is go ahead and give me a IR. I'm gonna place my IR in the machine. Nope.
I will help you.
DQ is done. Partner's gonna run that for me. All right. I'm gonna ask my patient here. I'm gonna take the DQ holder away. Alright, we are now detented. I'm going to move him into an LPO position. It's an AP oblique. So, sir, we're going to go ahead and roll you down from where you're at. Perfect. He's going to be about 45 degrees. We got a good light field, 14 by 17 in the bucky tray. Just going to make sure that we're centered at the iliac crest. We're good. I'm gonna go ahead and shoot this about 110 at, or about 100 kV at 10. X-ray's done. I'm gonna come in here, taking out this 10 by, or this 12, 14 by 17. Gonna go ahead and put it in another 14 by 17. Still centering at the iliac crest. We're gonna have the patient roll onto their back, so making sure the tip is in. Still got the light on the on the tray and on the IP centered, so we're just gonna center our patient again. Centered to the midline, still centered at the iliac crest. We're gonna go ahead and shoot this again at about 100 at 10. X-ray's done. Coming in. Gonna switch out my IRs. Another 14 by 17. Bringing it in. Light still centered. I'm gonna have the patient roll up onto their right side. I'm gonna move, put in this piece right there, and roll them back. Alright. We want to be centered at the iliac crest and about 1 to 2 inches from the midline for this oblique. There we go. Other direction, other medial or lateral. So still centered at the iliac crest. Gonna go ahead and shoot this at about 100 at 10 again. X-ray is done. I'm gonna go ahead and put in my next film. It's gonna be another D-cube. So I'm gonna grab my decubitous film deal. Again, moving as quickly as possible so as to get our patient out of this joint. Gonna have our patient roll onto their left side. Get them as remaining, keeping sure the tip is still in, and we're gonna get them as close to the IR as possible. Gonna slide them back just a tad. You're doing great as far as Barium Enemas go. This is the best I've ever seen. Gonna go ahead and get our film and everything lined up with our light. Alright. Maintaining a distance of 40 to 48. Want to make sure we are centered. Iliac crest again. Get that a little lower. Alright, we're going to shoot this one at about 110 again. X-ray, we're good. Gonna have my partner's going, he's gonna get me a 10 by 12. He's running all our films, doing a great job. That guy. Alright. We're using a gridded cassette, and I'm gonna have my patient roll onto their stomach, all the way onto their stomach. Alright, we're going to take it's a lateral rectum shot, so we're going to shoot this cross table, get our patient as close to the IR as possible, and we're going to just bring our light a little higher up, centering on about where the rectum is, a few inches posterior to the body, on the posterior end. I'm going to make my light a little smaller. There we go. Gonna shoot this shot at about, again, about 100 at, maybe like 90 at 8. Done with that one. So, unfortunately I made the mistake, I forgot to do my sigmoid shot, so I'm gonna go back and do that while to my patient for my mistake, sir. I apologize for my mistake.
It's okay, sir.
You seem to be doing well.
You're doing great.
Thank you.
I'm enjoying this.
Are you? I'm gonna have the patient roll on to their left side. Actually, we're in this position. I might as well just have them roll up to their right side just a little bit. And roll up, perfect, right about there. This way, I'm gonna focus on the right colic flexure. Just had to think for a second. That's all that happens. I'm a thinking man. That's not the one. That's why it's really important to know your machines, because sometimes you look like an idiot because you haven't used a particular machine very often or ever. So that's. We're gonna lower our IR. Just gonna move it with some force and some ignorance.
Weird.
This one we're gonna center it about the as is, which is right there, really. Make sure our IR is centered. Move our patient into the light field a little better. Center of the body. Maybe a couple inches lateral towards the side that's down. Open up our collimator. And take our shot at about 110 again. At this point, we're going to have the patient, I'm going to have my partner run that last film and explain to the patient, I'm going to remove the tip now, and you're basically going to waddle to the bathroom, clenching your cheeks as hard as you can, and you're going to just basically use the restroom, and we're going to take one more shot after that. Okay? So you want to make sure, first off, that you deflate the tip.
It's okay, you don't have to deflate it.
I deflated it anyway, just in case.
Okay.
And we're going to go. Hold on, I'm going to move this stuff. I know, this is tough. This out of the way, everything out of the way, because we're basically going to pinch and go. Alright, so Alfredo here has evacuated his bowels, so we're going to go ahead and take a post-evac shot. It's a 14 by 17, centering at the iliac crest. Yep, we're good. Centering at the iliac crest, which we are centered at, just to make sure he is also centered to the IR. There we go. I'm going to shoot this at about 110. So our first shot that we want to take a look at is the Scout. We shot that one at the very beginning. It's a KUB, so what you need to focus on or make sure you have is you have diaphragm all the way down to the pubic symphysis. Your large intestine should be within that space. The next one that we shot, we did the left lateral D-cube. We're checking out the air and fluid levels in the large intestine, and we're focusing on the lateral side of the ascending colon and the medial side of the descending colon. Our next shot that we ended up taking was the LPO, AP oblique projection. In this shot, we want to focus on, or the main thing we're trying to see is the descending colon, and trying to open it up a little bit so that you can see everything that's going on in there. Our next, and it's also the right colic flexure, is the main focus right there. The next shot we took was, we ended up doing an RAO PA axial, and its focus is more so on opening up the sigmoid colon. This patient as we see in other radiographs, their sigmoid colon and their transverse colon, they're all kind of bunched up down there. So we're trying to elongate that and open it up more to better see the sigmoid rectum area. The next shot that we ended up taking was an RPO AP oblique. We're looking at the left colic flexure, as well as the descending part of the colon. We have our RPO. Let's see. This is the RPO oblique. This one is on the left colic flexure and the descending part of the colon. This other one that we were looking at was the AP. I apologize. AP. And this is trying to visualize the whole large intestine. Forgive me, please. And let's see. Our next one, we did the right lateral decubitus. We're looking at the lateral descending part of the colon and the medial part of the ascending colon is the main focus, and also the air fluid levels in there. Our next shot, I believe, is the cross-table lateral rectum. You're trying to visualize the rectum basically from the end of the sigmoid colon out towards the anus. So there's our rectum shot. And lastly, we have a post-evac, which is visualizing the whole large intestine after the patient has gone and used the restroom. So there is all of our